Good morning. It's Dr. Rutledge, and I was a small part of a hot topics from the IBC last night, and the topic was marginal ulcers, and I thought it was pretty off base. I didn't think they did a very good job. I mean, all very good surgeons, and anyways, I had some different ideas, and I didn't want to derail the discussions, but I just thought it was very confused and very different from my own opinions. And again, not wishing to disrupt anything, I thought I'd put them out on a video this morning. It's only a portion of what new research and new ideas we have, so I'm just going to present them to you here. So I'll go through some slides and see if you have an interest. Let me know. Okay, so this is from another presentation that I've had in the past, and not sure how much time I'll spend on it with you, just give you a few things. But I was talking about the mini-gastric bypass and technical errors and tips and pointers. So I have a lot of videos and shots of surgeons claiming to be doing MGB from Australia, South America, Mexico, Europe, the Middle East, India. And what I would say is they're doing a bad job of it. Not a bad job in their own mind, of course, but a bad job in the way I view that we should be doing a mini gastric bypass. And so here, as I say, technical errors, and often the surgeon is the problem. And this whole presentation, which I probably won't go through this morning, is talking about twisting the pouch and kinking it, and particularly ischemia, which I think was a point that was missed this morning. And so I'm going to talk a little bit about that. And it's something that I see a lot of. And when I have patients who contact me with problems, sometimes we can get the surgeon's video, if not of that case, of at least the way he does the cases. And often you can pinpoint the problem. And sometimes the surgeons have been open to listening to me talk about this set of errors that can harm the patient and make their outcomes worse. And so I'm going to do a little bit of that today. So I guess we'll get started. Now, what was completely left out is dietary choices, lifestyle, and marginal ulcers. And not just marginal ulcers, but gastritis, ulcers, gastric cancer, reflux, esophagitis, and esophageal cancer. And I'm not going to go into that this morning because it's a long presentation and I don't have it all in place already. So I apologize for that, but I'm leaving out maybe one of the major portions of this. So don't think if you fix your ischemia and your gastrojejunectomy, you're done. There's a lot more to it than that. And also I point out that it wasn't even brought up except for maybe one slide here talking about cigarettes and alcohol. And then they moved on because that was that. But I think there's a lot more to it and a lot of misunderstanding there. And I'll try and do another video on that if there's interest. So if you contact me, and maybe we could even do it together online, I'll go through the discussion with you. The other thing is this, there's new information for those of you who are unaware. H. pylori and our battle against H. pylori, which now is something over 60,000 years long, because they found H. pylori in the earliest specimens of man that they can judge, is changed a little bit. So, for example, I don't know everywhere, but I know Europe has an aggressive policy of testing and eliminating H. pylori in their pre-patients because of the fear of cancer. Problem is that the studies that have looked at that haven't come out as they thought. What happens is you're basically inducing an H. pylori resistant strain of bacteria, which may not be a good idea. So people said it with conviction that you need to find H. pylori and kill it. And that approach is now being brought up for question. There's a lot of new research. And the other thing is when you treat H. pylori, including the PPIs, you actually allow it to migrate its infection up into the body of the stomach. And so there's a lot of new research there, which I didn't get the impression that people were actually aware of when I brought it up. So that's another presentation that might be worthwhile. Now I'm going to mention a couple of things that seem obvious, which were kind of dusted under the rug last night, which is number one is First of all, overall, the incidence of marginal ulcers is relatively low, but it's particularly interesting because some people have almost none and other people have a lot. And these low versus high rates, I kind of brought up, and no one kind of had much to say about it. They didn't appear to think much of it. They say, well, blah, 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 and went on to the next topic. But I think it's very important. In other words, why would you see some surgeons have very high rates and low rates in others? Well, you could assume bad data collection, bad follow-up, or things like that. But what if we had two groups who had excellent follow-up and excellent data collection, and you saw low versus high? Well, my bias is that the surgery can be different in different surgeons' hands, and I call this the Y omega effect. Y omega published an article saying MGB was terrible. And everyone said, well, this must be good because it's a controlled prospective trial. No, it's a controlled prospective trial between surgeons roughly incompetent in performing the MGB, roughly unable or unwilling to talk to a member of their team who's superb in performing the MGB. And so they got bad results and said it's the MGB. Well, maybe. My conclusion, seeing hundreds and thousands of MGBs done and MGB patients, that it's the Y omega surgeons. And in the same way, the difference in marginal ulcers, I think, should at least be considered that it's a surgical technique, because that's so easy to fix. I think surgeons are so sensitive emotionally and ego, they're so frightened of discussing it. But one of the surgeons last night said they changed from a staple to a hand-sewn technique. Well, I don't necessarily agree with that, but at least he paid attention to technique. Okay. The other thing that was implicit in the discussion last night, well, acid is it. Acid is the cause. But that seems like very strange for a couple of reasons. One is acids everywhere in the gastric pouch, and marginal ulcers are only at the margin. Now, there are rare cases of other locations, but 99% of ulcers are at the margin. Well, why? If acid is everywhere, what's special about the margin? Well, the obvious answer is that's where the blood supply is weakest and where ischemia can be largest. So maybe we could pay attention to the etiology of marginal ulcers is the margin. And some surgeons' margin is different than others. This seems so obvious, so clear, and not one person seemed to get it. So I don't want to be critical, but I'm going to just say this again. Marginal ulcers occur at the margin. Why? Well, obviously, acid is everywhere, and the blood supply at that gastrojejunostomy is potentially variable depending on how it's done. In fact, the Mayo Clinic surgeon commented he had switched to a hand-sewn technique. Hello, it's possible that the way it's being done makes a difference. Okay. Now again, people are getting marginal ulcers and they have PPIs and everybody's saying it's acid. All right. Hello. You know, we used to have acid ulcers. We used to have acid ulcers. We had peptic ulcer disease. I was trained in that. Many surgeons did operations for peptic ulcer disease. We don't do those operations anymore because we have PPIs. The ulcers are eliminated because we eliminate the acid. So there are people talking last night, well, bigger pouch has more acid. Well, you have PPIs. All right. Just as a reminder, I got this quote. There's 1,000 quotes, but as if the presenters last night don't know this, the impact of proton pump inhibitors. In the stomach, PPIs induce a profound hypochlorhydria. That means no acid. The serum concentration of PPIs peaks at 2 to 5 hours, and after 3 to 4 hours, a single oral dose of PPI will raise the gastric pH in most patients from 2 to over 6, a 10,000-fold change. What is the acid? Yes, there's a little acid, but most of the stomach and the rest of the gut does fine with that acid. The one place it doesn't is the margin. Why? I'll wait for you. Take your time. Why is it the margin? It's not the acid. All right. So why marginal ulcers? Highest soon after surgery. This is another thing that people couldn't figure out. I mean, they mentioned it, but just, okay. Why would marginal ulcers be most prominent soon after surgery, okay? Let's just think about it, all right? Now, if it was acid, that means the longer you go, the more acid. So at 10 years, you'd have lots of marginal ulcers, and at 10 days, you'd have none because there's not much acid. The acid exposure time under the area under the curve is greater as the time is longer, but that's not what we see. On the other hand, what time is the greatest ischemia at the anastomosis? I mean, remember your basics, you have general surgery. Come on, guys, wake up. That's the greatest ischemia is right after the surgery, and particularly the first 7 days. So, of course, if blood supply is important, that is, if ischemia is important, then, wait for it, then marginal ulcers would be more common if ischemia was important, and ischemia is higher in the hands of surgeons who decrease the blood supply to the gastrojejunostomum. Again, why are marginal ulcers different in different surgeons' hands? Because different techniques affect the blood supply. Do you see where we're going with this? Techniques affect blood supply. And I have loads of slides and videos on this. Surgeons put their videos up online, and it's just hilarious to watch sometimes. All right, let's go through this technically, and then I'll stop because I think I'm kind of beating a dead horse here. But okay, let's imagine this is a pouch, right? So here's the lesser curvature, and this is the vasculature. So all blood supply to, say, this part of the stomach pouch has to come from here, all right? This is just basic. I mean, I'm sorry I have to go through this. This seems like it should be so obvious. All right, this is the neo-greater curvature, I'm going to call it, because remember the gastric remnant is over here, all right? Now, if we do a stapled gastrojejunostomy here, for example, that means there's a possibility of blood collateralizing and flowing and providing life to this potentially ischemic tissue, all right? If we move this staple line close to that staple line, or we use large figure of eights and we just kill all that tissue, then you have ischemia, all right? Stricture, ischemia, foreign body, ulcer, gastritis, and even worsening bile reflux, which wasn't really talked about much last night, but we could talk about it if you want. So what we want to do here is just an example of we have to remember where the blood flow comes, and how we do this can affect marginal ulcers. Anyways, I'll stop there, but I was pretty frustrated with the level of discourse last night, given the fact that we had some really good people there, but a lot of foolish stuff, in my opinion, was said. I don't mean to be critical, but have a good day, and if you wanted to talk more or see the other bad surgical procedures that I've got in the next slides, please contact me. Thanks very much. This is Dr. Rutledge.